potential, usually at the ceiling level of the floor below. So the static magnetic field exists all around the magnet, but obviously not at a uniform strength everywhere. This is magnet vision, and this allows us to visualize the static magnetic field. So what we're looking at right now is a windowed and leveled version of the static magnetic field. And actually, we switched to different views. So this is actually now looking at the spatial gradient. Let's see if I can rewind and replay that video here. Is it playing? Yes. So first we're going to see the static magnetic field, the V sub 0. And again, it's windowed and leveled, so we're not seeing the values out away from the bore, although there are those. You'll notice that there are these little white areas. So this is a 3T magnet, and at the resolution we can't really see, but this area right there is actually like about 3.6 Tesla. So your 3T, when it says 3T, it's giving you the value at isocenter. There are areas within the magnet where the potential exposure to the magnetic field is greater than what the system is rated for. This is the spatial gradient. This is the spatial gradient, again, is the rate at which the magnetic field either gets stronger or weaker as we go closer or further away from it. One of the requirements for MR imaging is that we have to have a homogeneous, a uniform static magnetic field where we take the pictures at isocenter. So you'll notice that in this illustration, there's no coloring, there's no shading at isocenter where we have this patient's head position. There's no spatial gradient at isocenter because we can't have one there. We have to have a uniform magnetic field, and a spatial gradient is, by definition, a changing magnetic field. Spatial gradients for bore format magnets almost always are greatest at the mouth of the bore, where the horizontal tube tapers into the front face of the magnet. Somewhere on that curve, from where we go from horizontal to vertical, somewhere in that transition is where the spatial gradient is highest for every bore format magnet. This is true for GE, Siemens, Philips, Toshiba, Hitachi. Whatever magnet you have, if it's a tube-style bore format magnet, that's the region where the spatial gradient will be greatest. It's also radially symmetrical, which means we're really describing an area around the opening, not just at one point, but that value is consistent around the opening. And then it drops off fairly rapidly as we get away from the opening. So static field, if it's a 1.5, we're talking about it's 1.5 where we're taking the pictures. And in an area probably around here, it's similar to where the maximum spatial gradient is. We'll also have a maximum field that will be higher than 1.5 if your magnet's 1.5, or higher than 3.0 if your magnet's at 3.0. These illustrations come from Magnet Vision. Magnet Vision has, in the current version, almost every one of the GE magnet systems, and it has the full three-dimensional modeling of static field, spatial gradient, and the others, and we'll take a look at those next. Come down, there you go. Here we go. Time-varying gradient magnetic fields. Unlike the static magnetic field, time-varying gradients are only present when we are imaging. Walking around the magnet, positioning the patient, anything that's not actively acquiring an image, there's no time-varying gradient. Apart from the silent scan or the quiet scan options now, it's pretty easy to tell when the time-varying gradient is going, because that's when that horrible sound is being made. time varying gradients outside the bore. So if you're standing next to the table while the patient is being imaged, time varying gradient exposure outside the bore is approaching 0. Similarly, as we discussed earlier, time varying gradients at isocenter are also approaching 0. So if it's 0 in the middle and it's 0 outside, the only place we can be someplace other than 0 is some distance away from isocenter, but before you get to the ends of the magnet. And that's where the maximum is. Tends to be about half the diameter of the bore of your magnet. So if you have a 60 centimeter magnet, about 30 centimeters. If you have a 70 centimeter diameter magnet, it's about 35 centimeters, generally speaking. Away from isocenter is where the maximums are. And we can illustrate that again using magnet vision. So we go, and we'll turn on spatial gradients. And these are cutting planes. There's an X and a Y and a Z cutting plane. So again, it's radially symmetrical. So what you see on the side here wraps all the way around the tube, all the way around the inside of the bore. So if we're imaging this patient's head, the time varying gradient within the patient's head is fairly modest. At isocenter, it's going to be close to 0. As we move away from isocenter, even just a few centimeters, we get some gradient, just not a huge amount. What this means is, if we're imaging this patient's head, the regions of the body that are likely to experience the greatest slew, the highest gradient amplitudes, are his chest and his arms. So the experience of peripheral nerve stimulation is almost never where we're taking the picture. If we're imaging the patient's head, we're very unlikely for that patient to experience peripheral nerve stimulation anywhere in their head, because that's where gradients are close to 0. Where they're greatest is 30 to 35 centimeters, either superior, inferior, or radially, away from isocenter. So iso, very low likelihood of peripheral nerve stimulation, gradient-induced neuromuscular stimulation. But as we travel about 30 centimeters up and down the length of the bore and then out radially, that's where it's going to be greatest. Radio frequency, like time varying gradients, only present during image acquisition. If we're not acquiring the image, there is no radio frequency energy present. Radio frequency energy also, like time varying gradients, if we're outside the bore, the exposure is approaching 0. If you're standing even at the mouth of the bore, outside the magnet, and the sequence is running, the amount of radio frequency energy that the patient gets, or pardon me, that a subject gets standing outside the bore is almost nothing. Radio frequency energy dies fairly quickly. I didn't include it in this presentation, but if you go into your operator's manual, every operator's manual is required by the IEC to give you a plot of radio frequency energy and radio frequency energy distribution in your bore. And that plot looks like a bell curve, and it gets real high in the middle, and then it dies off rapidly at either end. So at the magnitude of RF energy appears to be 0 at the mouth of the bore, and it appears to be highest in the very center of the bore. I won't say that drawing or that plot is a lie. It's not, because it's giving you the values along the central z-axis, right down the middle of the bore. What it doesn't tell you is what that energy distribution looks like anywhere other than right down the center. If you look at that plot, it would lead you to believe that the radiofrequency transmitters are right in the middle of the bore. And in fact, that's not the case at all. So here we're going to take a look at radiofrequency transmission. We're actually going to make a comparison between using a transmit-receive head coil, and we're going to look at the same study with a body coil. So here we're looking at radiofrequency power using a transmit-receive head coil. This is the radiofrequency transmit power using the body coil. Even if you're doing a head study, if you're using the body coil for transmit, remember the plot that I've described that your manufacturer has to include that says radiofrequency power is greatest at isocenter? Turns out it's about 20 centimeters superior and inferior radially. It's at the ends of the birdcage quadrature RF transmit coil. It is not maximum at the center. What this means is, if you're doing a head study and you're using the body coil for transmit, the most likely place that you're going to produce a burn in that patient is in their upper arm or their shoulder. Two reasons. One, because we have to get superior or inferior to the location that we're imaging to get to where those transmit rings are. And then we need to get radially. The power is greatest close to the wall of the bore. So if I'm laying in your scanner and we're doing a head study on me, my arms, my upper arms or my shoulders are going to be against the wall of the bore if we don't put that recommended padding in between me and the bore. Which means if we're doing a head study, again, using the body coil for transmit, not a transmit-receive head coil, then the likelihood of producing a burn, this is where it's most likely to turn out. You have a patient who has a large abdomen. If you're doing a C-spine, you may wind up producing a burn if that patient's abdomen touches the wall of the bore. The abdomen is going to be the most likely spot for a burn.
So should it cover the patient obese by sheet or something?
So if the patient is large, yes, you should cover them. A bed sheet alone won't give you the thickness that's recommended. Different manufacturers or different individual MR systems have different minimum thickness requirements. I think some of the Siemens systems have a minimum thickness of 5 millimeters. Some of the GE and Philips systems have 7 millimeters. Some of the old GE systems have a 1 centimeter minimum
so there is
thickness.
specific thickness.
So your MR system should have come with pads from the manufacturer that meet their minimum criteria. If you no longer have those, or if they've fallen into disrepair, you can get replacement ones either from the manufacturer or there's some third-party vendors of pads. But yes, in general, every patient who is having a study using the body coil for transmit, which is the majority of our studies, there should be, if they're skinny like I am, you know, and you feel confident that when you tell the patient, make sure you don't touch the sides, you know, you observe the position they're in, you make sure that they're not touching, and that there's adequate clearance. For those patients, padding really may not be helpful. But a larger patient, by all means, yes, you should make sure that there's more than just their clothing, or more than a gown or a bed sheet that separates them from the walls of the bore. You should use a padding that is at least the minimum thickness that's called out for that particular system.
And I think the short example alone, like brain and whole spine will take around 1.5 hours, and C-spine will take maybe 15 minutes.
So the question is, how important is the length of the exam?
Yeah.
If I have a candle burning, and I take my hand and I put it over right on top of the flame of the candle, how long do I have to wait before I get a burn? I can get a burn very quickly, right? If I leave it there for longer, I may get a worse burn. You know, the damage may be more severe. So one of the challenges is we tend to think of radiofrequency energy in terms of SAR, right? Body mass average rate of power deposition, 2 watts per kilogram, right? 2 watts per kilogram is not the same thing as 2 watts per kilogram if the patient mass is different. If you're doing an infant that has 10 kilogram mass and the next patient you do weighs 100 kilograms and you do a study for each of them that is 2 watts per kilogram, the amount of power is massively different because it's 2 watts per kilogram times 10 total kilograms for the infant times 100 for the adult. So the total amount of power being output before we normalize for the mass of the patient, it's 10 times more power for the adult. What that also means is when you have a large patient, you have an obese patient. When you see 2 watts per kilogram and you think, oh, that's normal mode, that's a modest amount of radiofrequency energy. When the patient has a large mass, you have to in your mind think, oh, it's 2 times 160 kilograms this patient weighs, and that's a lot of power. How many of you have had the experience of an old incandescent light bulb? You turned off the light and you went to unscrew the light bulb. I burned my fingers like crazy when I was a teenager, thinking, oh, you just flip the bulb, flip the switch, and then you can go and you can unscrew the bulb right away. Those incandescent light bulbs are 60 watts, 100 watts. If we take our 100 kilogram patient at 2 watts per kilogram, we're sending 200 watts of power into that patient. We're actually transmitting more than that. 200 is what we think the patient is absorbing. So there's even more than that in terms of transmitted power. Unscrewing a 60 watt light bulb, the primary purpose of which is to take energy and turn it into light, it just happens to turn some of it into heat as well, creates enough heat that it burned my hand badly at 60 watts. Now we're talking, 200 watts or potentially more than that. So the amount of power is fairly significant. So it's a two-pronged problem for our obese patients. Because they're large, we're going to transmit more power total to compensate for their larger mass. And because of their body habitus, they're going to be closer to the transmitting elements. So they're closer to it, which is more dangerous, and we're transmitting more power, which is more dangerous. So the padding, especially for our large patients, is extremely important to try and prevent burn injuries. If you have transmit-receive anatomy-specific coils, head coil, knee coil, take a look at this in terms of the amount of radiofrequency power. How much radiofrequency power is in this patient's thorax? Effectively 0. Transmit-receive head coil, transmit-receive knee coil, transmit-receive foot and ankle coil. If you can't see the anatomy expanded to the maximum possible field of view, the reason you can't see anatomy is because there's no signal. The reason there's no signal is because there's no radiofrequency energy incident on those tissues. Max your field of view on a transmit-receive coil, And where you see anatomy is where that patient is getting radio frequency energy. Where you don't see anatomy is essentially where there's too little radio frequency energy to produce any meaningful signal. So that gives you a pretty effective map. In most cylindrical coils, like a transmit-receive head or transmit-receive knee, you can look at the coil itself, and where the cylinder ends, maybe a centimeter beyond that, the tissues get radio frequency energy in some meaningful quantity, but you go much beyond that, and they don't. So let's transition to MR conditional labeling and MR conditional implants. When a manufacturer submits their implant to get MR conditional labeling, in the US at least, the FDA is the organization that approves MR conditional labeling. And they have some general standards about how you're supposed to conduct the test to get the data that demonstrates that the product is safe. So the test parameters are pretty well defined. What isn't well defined is the variables associated with the test. So if I'm an implant or device manufacturer and I want an MR conditional label for my coronary stent, right? I can decide that it is cheaper or easier or less of a headache to only test it at 1.5 and not test it at 3. Or maybe I have a friend who has an old, 0.3 low field, permanent magnet system, and he'll test it for me for free, and so I can collect the data on a 0.3 system. It doesn't matter that most patients who would get this implant are probably going to need to be imaged at 1.5 and maybe 3. I'm not obligated to test it under systems that the patients are most likely to need exams on. I can test it on whatever system I want. I can set up the test so that I'm concerned about heating, and so I want to make sure that I test it in a way that it doesn't heat, so I don't jeopardize the opportunity to get my MR conditional label. So I can take my implant, my device, and I can instruct the place where the test is being conducted. I only want you to test this at 0.1 watts per kilogram of RF power, because I know I'm not going to have dangerous heating at that level. And so the site tests it at 0.1 watts per kilogram, and they say, guess what? There's no significant heating. So now I can go to the FDA with my testing information, and I can say, I tested this at 0.3 Tesla. I ran pulse sequences at 0.1 watts per kilogram, and none of the safety parameters were exceeded. And the FDA is duty-bound to say, if you tested it and it didn't exceed the safety thresholds, we will approve MR conditional labeling for this device. Again, it doesn't matter that it was tested under conditions that nobody in the real world is actually going to experience. They can get an MR conditional label based on that. So it's important to understand that when you see MR conditional labeling, it is not necessarily the safety threshold. It is the condition under which a manufacturer wanted to have their product tested. It may be so far below any safety threshold that you might be able to double the conditions. You might be able to take those conditions and multiply them times 10 before you even come close to a potential risk, a potential harm. I'll give you an example of this. I was working with an implant and device manufacturer. They had, years ago, they had tested their implant for spatial gradient. And similar to what I just described, the test for spatial gradient is you take the implanter device, you set it inside the magnet hanging from a string, and you measure the angle at which the device is pulled towards the magnet. And you put the test in a specific position where you know what the spatial gradient is in that location. So you look at the string, and as long as the string didn't deflect 45 degrees, if it deflects 45 degrees, that means that the amount of pull into the magnet is the same as the amount of gravitational pull towards the ground. The theory being that, well, the object of the implanter device is constantly under one gravity of force that's pulling it down. So we know that if there's a 45-degree deflection and it's pulled with one gravity of force that direction, that's not more than it experiences being pulled this way all the time, so presumably that's safe. So 45 degree is the magic threshold. So we put this object in a magnet, and we know what the spatial gradient is in the test location. It's 720 Gauss per centimeter in a certain GE system. So we set the test rig in the mouth of the magnet, and we look and we see, did it deflect less than 45 degrees? And if it deflects less than 45 degrees, the FDA says safe. Did it deflect 1 degree? Or did it deflect 44.9 degrees? We don't know. So I was working with this implant manufacturer. They had done the test many years before, and it had deflected 3 degrees. Their MR conditional label prior to me being involved with them was 720 Gauss per centimeter at 3T is okay. Now, there are lots of places in and around magnets, especially 3T systems or even high field opens, where the spatial gradient is higher than 720. And so this manufacturer wanted to update their labeling. So there's, you can do what's called an extrapolation test. Mathematically, if you know that it extrapolated, or that it deflected 3 degrees under a certain set of conditions, you can do the math and you can figure out how much would it need to be exposed to make it go up to 45, the magic tipping point, right? So this manufacturer had gone through the test. They had done the extrapolation to figure out, you know, how much higher they could label it. And they sent their calculations to me to review. And I took a look at the calculations and I said, there's a math error here. You guys did it and you came up with, I'm making up the numbers, 7,000 Gauss per centimeter. I ran the numbers and you had a math error here. It's actually double that. It's 15,000 Gauss per centimeter before you get to this threshold. And the manufacturer said, they responded back to me and they said, oh, thank you for pointing out the math error. Our attorneys are telling us to label it with the lower value, label it at 7,000, even though when the math showed that you could label this up to 15,000. So they purposefully downgraded the labeling to try and make sure that people didn't push the envelope, that they didn't, you know, do something that in theory, at least to the attorneys, might expose the implanter device company to some greater liability. So even though they went from 720 to 7,000, they increased it by a factor of 10, they could have doubled that. They could have increased it by a factor of 20 before they even got close to a theoretical safety limit that really isn't a safety limit if the exposure this direction is the exact same thing as the exposure we always have this direction. By the way, if I do this, I just expose my entire body to 2.5 gravitational forces, G's, acceleration when I landed. If I didn't dislodge my coronary stent when I did that, why is it going to dislodge if the deflection is 46 degrees horizontally? It's not. But that's just sort of the test conditions, the parameters for testing and labeling.
Sometimes the implant depend the company. I mean, like ICD, we need sitting before the MRI, specific sitting for MRI. So it's compatible with MRI, but we need sitting for that.
Right. Yes, so with active implanted devices, nowadays there are lots of them that have settings or you have to check beforehand and then you have to check after. Yeah. There's CSF shunt valves. You know, there's some that are magnetically activated, and you expose them to the magnetic field, and you can actually dial up or dial down the patency, the openness of the CSF valve, which can have negative effects to the patient. So yes, there's some where we need to verify prior to the study. We have to verify after the study. Pacemakers, ICDs, neurostimulators, there are many of them where we have to program them into a specific mode to allow MR imaging to take place safely.
Yes, I have a question about the neurostimulation.
Yes.
All the, I mean, this advice should be before sitting or no? I mean, there is compatible, no need sitting before that. So,
question is for neurostimulators.
Yeah.
Do we need to put them into special MRI settings before imaging them? That's going to depend on the individual device and what that manufacturer describes. Before the break, we were talking, I made mention of Boston Scientific that for their MR conditional pacemakers, they now have ones that if it detects a strong magnetic field, it automatically switches it into an MRI safe mode. I suspect that that kind of technology is going to, spread into all kinds of active implantable devices, neurostimulators, ICDs.
Because 1 year ago I faced the neurostimulator for that. In the last moment, there is a neurostimulator, and we need before that sitting for neuro. Yeah.
So patients with neurostimulators or pacemakers that require programming or changing of the active mode, that can be difficult logistically to try and get a vendor rep from Medtronic or whomever to be able to come and bring the device that can interrogate the pacemaker or the neurostimulator, can verify its condition in terms of its ability to go into an MRI safe mode, and then put it in that mode and then take it out again afterwards. And that becomes an important consideration for any of these programmable active implanted devices. So what does it mean to go off-label? Going off-label or scanning a patient with conditions outside of the prescribed MR conditions on the label does not necessarily mean that you're subjecting the patient to greater risk. So I made up this artificial implant. So this is a vagal nerve stimulator that's MR conditional for 1.5 or 3 Tesla, spatial gradient 300 Gauss per centimeter, time varying gradients 80 Tesla per meter, 0.5 watts per kilogram radio frequency, and then those test conditions report a 1 degree centigrade rise in temperature over a 15-minute scanning. So vagal nerve stimulator we're talking about, essentially it's a pacemaker that instead of pacing your heart, paces your vagal nerve. So that's sort of an illustration of it. If we're going to scan this patient with the vagal nerve stimulator, if we're going to scan them off-label, if you scan them on-label, essentially what the implanter device manufacturer is saying is, if you follow my instructions, There is no particular risk to this patient for doing this study. The one exception that I'm aware of to what I just told you is cochlear implants. There are cochlear implants that have MR conditional labeling, and in the MR conditional labeling it says, oh, by the way, you may follow all of our instructions and the patient may not be able to complete the exam because the exam is too painful for them. The retainer magnet that's embedded in their scalp, in their skull, the force that's trying to twist that or flip that can be extremely painful to patients who have the vagal nerve stimulator, cochlear implant, the retainer magnet. So it says, even if you follow all of our instructions, it may be so painful the patient can't proceed. That's the only exception to the general principle, the only exception I'm aware of, where an MR conditional label means that if you follow the conditions, there's no specific risk to the patient for doing this. Now, for that guarantee to be in effect, you have to follow the conditions specifically. When you do, it essentially means the manufacturer of that implanted device assures you that there's no specific risk, there's no undue risk to the patient. So when we go off-label and we don't have that assurance from the manufacturer, how do we determine if there's a particular risk for that patient? So we need to ask ourselves several questions. What body part are we scanning relative to the position of the implanted device? What anatomy is going to be exposed to the static magnetic field? Generally speaking, you walk in the room and you're exposed to the static magnetic field. So this is a question of degrees to some extent. What anatomy is going to be exposed to the time-varying gradients? What anatomy is going to be exposed to the RF? I showed you the computer models, the animations, that show the distribution of each of those electromagnetic forces. Off-label does not automatically mean that it is dangerous. What off-label means is that it is untested by the manufacturer. Sometimes you'll actually find in literature, somebody puts out an implanted device that gives a ridiculously low RF tolerance, that RF condition, 0.2 watts per kilogram. Good luck trying to do a fast spin echo on that patient when you have 0.2 watts per kilogram. Maybe you get one slice with such a restrictive RF condition. So they put out this ridiculously low threshold value. And somebody out there says, well, we have a whole bunch of these patients who have this implanted device. I really think 0.2 watts per kilogram is absurdly low. What happens if I image these patients at 0.5? And so somebody will image 20 patients at 0.5 and they'll test the implanted device and they'll check on the patient and they'll see there were no adverse outcomes when I scanned these 20 patients at 0.5, and they'll publish a paper. The fact that it's out in the literature doesn't obligate the manufacturer to update their labeling and say, yeah, we had previously said 0.2, but now we see there's this research that says 0.5. We're going to upgrade our labeling. You can find that information in some cases for certain implants or devices. Doesn't change what the manufacturer represents as what they will stand behind. So off-label just means untested by the manufacturer. Sometimes you can find third-party testing published in the literature that will make you feel more comfortable in other areas or exceeding the values. But that doesn't have to be the only way. Actually, I'm going to go back here for a second. So I asked you to ask those three questions about exposures: static field, time varying gradient, and radio frequency exposure to an implant or device. So depending on where the device is inside the body of the patient, depending on how we're positioning the patient in the magnet for the study or studies that we're planning on doing for them, those things are going to dictate what the potential exposures are for static field and spatial gradient associated with it, the time varying gradient magnetic field, and the radio frequency magnetic field. So think about that, and I've actually got an illustration of that that's coming up here in a minute. Before we get to that though, the practical differences between 1.5 Tesla and 3 Tesla when it comes to MR safety. None, from an operational standpoint. In terms of what you should be doing in terms of basic screening of your patients, of hospital employees who come into the environment, MR safety training, access restrictions, 4-zone environments, those sorts of things. It really should not matter whether you're talking about 1.5 Tesla or 3 Tesla. Those operational elements of MR safety should be equivalent whether you've got a 0.7 or you've got a 7T magnet. The training, the access controls, those types of elements should be fairly consistent. Obviously, as we get to the higher field strengths, we have greater potential risks associated with things going flying. But if you're doing an effective job of keeping those things out of the suite when all you have is a 1.5 Tesla, if you get a research 7 Tesla magnet, you're at no greater risk because you ought to have been doing a great job of that at the lower field strength. Where the difference does come into play is with specific heating parameters. So we talked about radio frequency heating, and that one of the mechanisms of radio frequency heating is an electrically conductive element in the bore with the patient, right? There's what's called resonant circuit heating. You can think of this as the antenna effect. For every frequency of radio frequency energy, there is a specific antenna configuration that is super efficient in terms of absorbing radio frequency energy. It essentially inhales, it sucks up all of the available radio frequency energy because it's an antenna, that's its job. It's designed to collect the energy, collect and concentrate the energy. At 1.5 Tesla, the perfect antenna for the frequencies we use at 1.5 Tesla is a linear conductor oriented the same direction as the bore. So we're not going across the bore, we're going the length of the bore. A linear conductor that is insulated except for the very tips. The length of that at 1.5, that is the worst case scenario, is between 25 and 30 centimeters. At 3 Tesla, we use a different radio frequency for transmission. The Lamar frequency at 3 Tesla is twice the frequency at 1.5 Tesla. When we increase the frequency, we decrease the wavelength. We're packing more sine waves into the same second, same time period. So when we have fewer sine waves in a second, the distance between the peaks of the sine waves is longer. When we squeeze more of these into a finite space, a finite time, then the distance between the peaks gets smaller. The wavelength gets smaller. So higher frequency, shorter wavelength. Wavelength is what determines what is the perfect antenna. So At 1.5, linear conductor, insulated, oriented along the central z-axis, 25 to 30 centimeters. At 3 Tesla, twice the frequency, half the wavelength, half the antenna length, 12 to 15 centimeters is the worst case scenario at 3 Tesla for a linear conductor. Now, there are lots of different things in terms of the shape and the size and the orientation, whether it has loops in it or whether it's straight. RF antenna physics gets really complicated really quickly. So I'm not here to tell you that as long as, if you're at 1.5, as long as you're not in the 25 to 30 centimeter range, everything is fine. That is not the case. I'm telling you that 25 to 30 centimeters at 1.5 Tesla is the worst case. But then there may be other conditions that are bad, and we don't necessarily have to be at the worst case to produce a negative outcome. The general rule is as field strength goes up, we start worrying about smaller and smaller electrically conductive items. If you're imaging patients, if you have that 0.3 Tesla low field open that I talked about a little while ago, the object that you have to, we almost never heard about radio frequency burns at low field strength because the frequencies are so small, which means the wavelengths are so enormous, which means the conductor length that is going to experience resonant circuit heating is so long, we'd have to put, like, you know, a spool of cable that went out into the next room to get something that was of appropriate length, that it would be the right antenna for those low field systems. As we move into the 1.5 and we get into the 25 to 30 centimeters, now we're concerned about things like 25 to 30 centimeters is close to the length of a pacemaker lead. It's close to the length of the lead of a deep brain stimulator. Some neurostimulators have lead lengths that are in the 25 to 30 centimeters. The MR conditional devices today, they have done amazing engineering to reduce the likelihood, even if the length is that perfect length. They've done all kinds of amazing things with the cable, the lead configuration, the material, the construction of it, that reduce the likelihood of heating for these MR conditional implants and devices. So the other thing I don't want you to take away from this is the idea that everything at 25 to 30 centimeters is dangerous at 1.5. If it's MR conditional, the manufacturer is standing behind their assertion that it is safe as long as you follow the conditions of this. So generally speaking, in terms of safety for 1.5 to 3 Tesla, if we're talking about what I think are the three elements of MRI safety. I think MRI safety is like a three-legged stool, and that we need to have clinical safety, operational safety, and physical environment safety. We may change a little bit of our clinical decision-making as we go from 1.5 to 3, based on the length of an object and its potential for heating. But operationally, in terms of how we screen patients, how we train our staff, our physical environment, how we restrict access, those sorts of things, these two legs of the stool shouldn't change. Anything that you want to do at 3T are things that you ought to be doing at 1.5. The only element that really is going to change, potentially, is clinical, and that's really related to implant and device safety. And particularly, other than sort of the overt MR conditional labels that say, yes, it's okay at 1.5, but no, not at 3. Other than that, the thing that we're worried about is the difference in length of an electrically conductive material and its potential for resonant circuit heating. As I mentioned, as the field strength increases, frequency increases, which means wavelength gets smaller, which means the length of the object that we're concerned about gets smaller. The US FDA right now has a draft guidance document out for MR conditional implant device testing. And their draft guidance essentially says they're changing their criteria for testing, and the new criteria, if they pass it, will essentially say, look, if you're 2 centimeters or smaller, if you're a coronary stent that's 2 centimeters or smaller, don't even bother doing the RF heating tests, because that is so small that for 3T and lower field strengths, there's essentially 0 opportunity for it to heat at that size. Now, I think that they're being overly conservative. I think Dr. Canal has previously said that in his view, that number should probably be about 5 centimeters. That once you get 5 centimeters and smaller, the likelihood of something heating significantly at field strengths up to and including 3 Tesla, 5 centimeters and below, is the likelihood of heating is almost non-existent. Heating above and beyond what you're generally doing to the tissues with diffuse heating. So we're talking specifically about focal heating and causing tissue damage or burns with that. So the US FDA is floating tentatively a 2 centimeter threshold. Dr. Canal's stated threshold is about 5 centimeters. I'm inclined to, I was in contact with a friend who works at the US FDA who's doing research. He was actually pushing for, not related to this draft guidance, but with his own research, he was pushing for a 5 centimeter threshold as well. So that's kind of where I fall right now, is if it's 5 centimeters or less, I don't think it's a significant risk for RF heating, for something internal to the body of the patient. When you get to things that are partially in the patient and partially out of the patient, that are electrically conductive, guide wires, not a terribly frequent occurrence, rectal temperature probes or something like that. When something is both in the patient's body and outside the patient's body, now all of a sudden the heating criteria gets really bizarre, because there are actually 2 different, the length of an antenna that produces resonant frequency heating results is a product of the media that it is within. So if that media is the human body, that's when we have the, for 1.5, the 25 to 30 centimeters, for 3 Tesla, the 12 to 15 centimeters. You take that exact same wire, and now instead of being inside the body, now you pull it outside the body and it's in air. Now all of a sudden the resonant frequency length that it takes to produce heating in it changes dramatically. It actually gets much longer in air than inside human tissue. So when something is partially in the body and partially out of the body, now the same object can experience resonant circuit heating at 2 very different lengths. And so it gets very complicated very quickly for things that are both inside and outside the body simultaneously.
I think inside more dating or...
Your question is there greater heating inside the body than outside?
Because there is, H2O inside soft tissues, that's meaning more...
So, yeah, yes and no. Depending on where it is, it may experience greater insulation inside the body. If whatever the object is in adipose tissue, is in fat. Fat is a tremendous thermal insulator. If it's in adipose tissue, any heat that collects in that object is not going to dissipate very effectively. If that, let's take my pacemaker lead as an example. So one of the leads is actually going to flow down the aorta, you know, into the patient's heart. So that lead that's floating in the aorta is getting a constant bath of moving blood flow across it. And so any heating that it experiences along the length of it is that heat is going to be easily transmitted into this, you know, moving fluid heat sink. The heat exchange will be fairly efficient across that boundary. So I would be careful about presumptions of if it's inside the body, it's more likely to heat up as opposed to outside the body, because it's really going to depend dramatically on where within the body and what the thermal characteristics of the tissues around it are.
The exam, within the exam.
Depends on the exam. Well, the heating will depend significantly on the exam. Anxiety, claustrophobia, sedation, and anesthesia. In my opinion, anxiety and claustrophobia are not safety issues unless we get to the point where we're talking about sedation or anesthesia. They are patient comfort issues, absolutely. And I don't mean to suggest that they're not important, but we're not at risk of harming a patient if they have an uncomfortable reaction to being in a confined space. Once we start sedating them, or they sedate themselves, and the patient is altered in some way and maybe isn't able to accurately participate in their own screening, or it somehow compromises their ability to be an accurate historian of what medical processes, procedures they've undergone in their life, now that begins to compromise safety. When we go to anesthesia, heavy sedation or general anesthesia, now all of a sudden we're actually compromising the regulatory functions of that patient's body. You may compromise respiration. And so we're going beyond just sort of potentially impairing their cognitive functions and reducing their ability to be constructive in their own safety. Now we're actually talking about impairing their physiologic function. The Columbini accident that Ms. Merriam described in the very beginning, the reason they brought the oxygen tank into the room is because they over-sedated the child. They gave him a sedative and he was calm, and they wheeled him into the room and he pushed through the sedative and he became agitated again. So they gave him a second dose of sedative, as you know, to calm him down before they moved him onto the table. Got him on the table, he was still calm. They put the top piece of the head coil over his face, and he pushed through that second dose of sedative, and he began getting agitated again. So they gave him a third dose of sedative before they advanced the table into the scanner. And then all of a sudden his O2 saturation levels started dropping. I won't go into any detail about the direct risks to physiologic function and patient safety as a result of anesthesia. That's really the domain of the anesthesiologist. What I will say is that anesthesia and respiratory teams are one of the most infamous sources of MRI accidents and injuries that exists. Sometimes it may be because they feel as though their title as physician means that they can do whatever they want, wherever they want. Maybe they feel as though they don't really need to follow the protocols of an MRI environment for safety, for screening, for their own individual activity. Maybe they don't feel like their equipment should really be subject to the inspection of the MR staff or review of what they're going to purchase. I'm of the opinion that if you come to my house, number one, you are my guest. I will do everything I can to make you feel comfortable. But number two, you are in my house. You play by my rules. When anesthesia comes to your house, anesthesia should play by your rules. You wouldn't go to the OR and start telling the anesthesiologist that, really, you have this set at 6. I think it would be much better if you set it at 4. When they come to MR and they dictate or try to dictate, what piece of equipment they should use or whether it should be subject to screening, that is the equivalent of you walking into the OR and telling them that they have the wrong setting on the anesthesia machine. They wouldn't tolerate it if you did that. Similarly, and they would be right to not tolerate it if any of us did that. Similarly, if they come to MR, they need to understand and appreciate that they are playing by the rules of MR. And there should be, in fairness to both you and to anesthesia, there should be a very bright line that defines that boundary. That MR will not say or do anything that will directly get between that anesthesiologist and the care of that patient from a clinical standpoint. I'm not going to tell you how to do your job. I am going to tell you that if you come into the MR suite, that everything you bring needs to be MR conditional, so that I know that whatever you need to do to take care of that patient, I don't have to worry about that. And as long as those ground rules have been laid in advance, then there really should be no conflict between anesthesia and radiology in terms of the care of the patient in the MR environment.
Excuse me?
Yes.
I think medical city, there's 2 areas. There is recovery area to sedate the patient. After that, we will push the patient inside the room. So all the machine for anesthesia outside of the room, in the recovery room. So I think it's more safe. So it depends the machine, it's compatible or not compatible.
Yeah, you're right that it's very dependent upon how the facility operates. KFMC, I will brag on myself a little bit because I was one of the people who actually designed the MRI suite at KFMC. And we created the anesthesia induction area, the patient preparation area, specifically to address that concern. Lots of hospitals, lots of facilities are planned without the expectation that anesthesia care is going to need to be delivered as a part of MRI. And so that becomes sort of an afterthought. Oh, how are we going to prepare the anesthesia patients? Well, we'll have to do it, down the hall or on a different floor. And then things can get really complicated in terms of patient care. So when we start talking about anesthesia care, anesthesia, the equipment, the personnel that gets brought to MR, we're really talking about risks to 2 different populations. We're talking about risks to patients. This is a fatality that occurred in MR, a general anesthesia patient. From the news accounts, it does not appear that doesn't appear that there was a problem in terms of the anesthesia machine was not MR conditional and that was what caused the problem. That doesn't appear to be it. What does appear to be at least contributing to this girl's death is when things began to go badly for her, there was not a clear set of actions that have been prescribed, in terms of how we're going to deal with a patient who is sliding into respiratory distress. Who's going to take care of it? Where are we going to respond to this patient's clinical concerns? Do we have a space designated for anesthesia care where we can actually ventilate the patient, bring supplemental oxygen? How do we care for this patient? In this facility, they really didn't appear to have those kinds of plans or infrastructures in place. I raise this because it's not just a question of, do we have an MR conditional anesthesia machine? It's, have we planned for how we're going to take care of these patients if things go badly? Those procedures are in some ways as important as the equipment and the device itself. And when those policies, when those processes are not clearly defined for everybody in advance of a patient care situation, when something does go badly, there can be total chaos. And anesthesia may not know what MR is trying to do, and MR may not know what anesthesia is trying to do, and nobody may know where we should take this patient to try and get them the clinical support that they need. So if at your facility you provide heavy sedation or general anesthesia care, please make sure that these processes for critical patient care, that these are defined in advance. It's not enough just to have the MR conditional device. Having a coordinated plan is also essential. With respect to staff, a significant proportion of projectile-related accidents injure radiographers or radiology nurses, in addition to striking patients. So we need to be concerned with respect to anesthesia, but anybody else who comes into the MR environment, concerned with respect to their equipment to make sure that it is appropriate to the environment, because it is not only the patients who are being put at risk, it's the radiographers, it's radiology nurses, it's anybody else that's in the room as well that is potentially at risk. I don't have them in the slide presentation, but I can show you adverse event reports to the FDA of anesthesia equipment inappropriate to the MR environment that is brought in and winds up harming the anesthesiologist themselves, or the anesthesia nurse, or the radiographer, or a physician in the room. It has happened repeatedly. So this is not just a question of patient safety, this is also a question of safety for your staff. Developing trends. These are some new devices, newer devices that complicate safety in the MR environment. PET MRI requires that we address both MRI safety and the zoning and the shielding, as well as shielding for radiation protection. The patient flow, patient preparation, and potential exposure once we've dosed them with FDG and the patient is now radioactive. The flow and access restrictions associated with radioactivity, and the flow and access restrictions associated with the 4 zones don't match up perfectly in every instance. And so it takes some careful planning and thought to make it so that you don't compromise the safety of radiation exposure in order to achieve the 4 zones, or vice versa. They can be done in harmony, but it requires mapping out the functional process and recognizing that in some cases maybe you have a PET MRI, but you only have enough patients to use the PET function 3 days a week, and the other 2 days a week you use it just as an MRI. How do you segregate all of the radioactivity purposes? How do you segregate the hot lab, the uptake rooms, the areas that may be exposed to radioactivity from just your MR patient? So the planning of these facilities becomes really challenging. Also, cross-training of radiographer staff. Nuclear medicine and MRI are very different professional paths. So do you have 2 radiographers sitting side by side, a nuclear medicine technologist and an MR technologist? Or do you cross-train and you give nuclear medicine skills to your MR radiographers or vice versa? So from a staffing standpoint, making sure that you maintain competencies, clinical and operational from a safety standpoint, that becomes a challenge. Intraoperative MR systems. This is one of the IMRIS ones that actually the MR moves along a track on the ceiling. There are other systems where the MR is stationary and you move the patient back and forth. So this is similar in that, similar to the PET MR, because here we have infection control protocols for who has access and when we allow them to have access, what they have to go through to prepare to gain access to the suite. That generally sounds an awful lot like the PET MRI and the PET function. It's just now we're doing it for infection control purposes, which has slightly different mechanics associated with it. But again, it is not inherently, doesn't necessarily play well with the 4-zone principles and access restrictions, access controls for 4-zone. It can be done well, it just out of the box, the default solutions from the equipment vendors isn't going to get you there. And it's something we need to think about. One of the complications in these OR environments is a lot of times, especially with these moving magnets, we may use conventional surgical devices. We may use conventional scalpels and hemostats and things that would go flying at the magnet if the magnet was in the room at the time. So procedures to make sure that we do instrument counts every time before the magnet comes into the room, or before we transport the patient into the adjacent room where there is the magnet, make sure that we don't have, scalpels or hemostats or clips or surgical tools under the drapes that can go flying. So procedurally, we need to change the way that we do surgery in response to the MR risks. Similarly, now we have cross-training issues because we have surgical staff who may not really have any meaningful prior exposure to MRI safety, and we have to impress upon them the importance of integrating safe practices to concurrent with their existing surgical practices. Perhaps the newest of these new devices is MRI LINACs, linear accelerators. These are really interesting because beam therapy, linear accelerators, primarily for oncology treatment, have typically kind of been limited to the extremities. We haven't really been able to do beam therapy in the thorax, in the abdomen, because simple respiration moves everything around in the abdomen. So we may know where a tumor is at one moment in time, but if somebody takes a deep breath, it may move 2 centimeters. And so if we're shooting a beam, we may be missing the tumor entirely. We may be hitting healthy tissue. The MR-guided linear accelerators actually do real-time MRI imaging, and they essentially watch the tumor move with pulse and respiration. And they know when the tumor moves into the crosshairs of the linear accelerator beams. They turn the beam on when the tumor is in the beam, and they shut the beam off when it moves out. So you can do beam therapy, linear accelerator beam therapy on a patient. You can do it in the thorax, in the chest and abdomen, and it will automatically correct for respiration and pulse motion of the tumor down to within a couple of millimeters. It's really amazing technology. This is one of the manufacturers. There are 3 or 4 different manufacturers now that have different types of systems. Like the PET MR, it requires a marriage of radiation shielding and conventional MRI radiofrequency shielding. Those can be difficult to coordinate together. With the linear accelerator, and the bunker construction itself is very unusual from an MRI perspective. So the radiation protection piece there is unusual. The good news is, unlike PET MRI, where we have significant patient preparation before the patient comes into the exam room, for linear accelerators, there's not an awful lot of patient preparation. We don't have to deal with radioactive materials like we do on the PET side. So while there is some coordination in terms of the 4 zones and radiation protection, this is actually an order of magnitude easier in this piece than the PET MRI is. And then again, we have staff cross-training because the oncology therapy techs who run linear accelerators generally don't know nothing about MRI, and MRI radiographers don't know nothing about linear accelerators and beam therapy. So again, making sure that clinical and safety competencies are effectively cross-trained are really important. So as we are coming towards the end of the presentation, I'm going to circle back to where we began at the very beginning. And I asked you, how many of you would consider imaging this patient, deep brain stimulator, 1.5 or 3T, 0.1 watts per kilogram SAR, those are the MR conditional labels. How many of you would consider doing an MR study on this patient with a transmit-receive knee coil? And I got about half of you who responded said, yes, you would consider it, and half of you said, no way, I'm not even going to think about it. Now that we've kind of gone through some of this material, oh, sorry, that's my next scenario. I'm jumping ahead of myself. Now that we've gone through some of this material, I'm going to ask you the same question again. We're doing a knee coil, transmit-receive knee coil. Where is the radio frequency with that exam? In the knee. Is it anywhere other than the knee? No. So, do we think a 0.1 watt per kilogram restriction on SAR, do we think that that's meaningful from a safety standpoint? Do we need to restrict the overall exam to 0.1 watts per kilogram when the closest thing to the area that we're studying is a meter away? Do we need to limit SAR? Do we need to limit RF exposure to the knee when using a transmit-receive knee coil when the closest element, the pulse generator, is a meter away? I hear some very quiet no's. Yeah. People who are uncomfortable speaking out about this. In my opinion, no. We don't need to moderate the radio frequency energy at all. Is this off-label? Does this contravene, go against what the label says the manufacturer will stand behind? Absolutely it does. Do I feel that this change, ignoring this limitation, do I feel as though that puts any additional risk on this study for this patient? No, I don't feel as though it does. Because I am quite confident that if we do a TR knee coil, the exposure at the implant is going to be well below 0.1 watts per kilogram. It's going to be so small, theoretically we could measure it, but I am 100% confident that it's going to be below 0.1. Is the exposure to the static magnetic field going to be different if we put this patient in feet first rather than head first?
The position feet first, right? Feet first
Right.
for the knee.
Yeah, for the knee. If we're putting them in, most MR conditional labels are written with the presumption that you're imaging the anatomy where the implant lives. Which means that if you're imaging something other than where the implant is, a lot of MR conditional labels are not very helpful because many times they don't describe, if you're imaging this body part, then do this. But if you're imaging this other body part, do something different. When you see just one limited set of conditions, it usually means that the manufacturer presumes that you're imaging the implant. Which is a good reason when you're not imaging the implant, if you have MR conditionals that only describe one set of conditions, to treat it with suspicion, to think that they're describing imaging the implant alone. If we put this patient in feet first to image the knee, as opposed to putting them in head first to image the brain, are we exposing them to a different quantity of static field?
Yes.
Yes, we are a little bit, because if we put them in head first, we know that that part with the implant, the deep brain stimulator, is going to pass through the mouth of the bore where the static field is the greatest. Where, when I showed you before, those little white areas where your 3T is actually 3.6, the US FDA says that's not important, don't worry about that. But if we put them in head first, we know that the implant is going to pass through that higher spatial gradient. We know that it's going to pass through the area where there's a potential for a higher static field exposure. If we put them in feet first, depending on the height of the patient, it may be that that's outside the mouth of the bore and outside the higher spatial gradient. If it's a short patient, we may actually be parking the implant at the mouth of the bore where that spatial gradient is the greatest. We would have passed through that, and so we would have exposed it to that if we were going in head first. So, worst case scenario is we're not exposing it to anything more if we have a short patient and we're parking this at the mouth of the bore. If it's a tall patient, if it's me, then the exposure to this will be less. Time varying gradients, I didn't put that up here as one of the conditions. If we're doing this patient's knee, would you be more concerned or less concerned than if we were doing their brain? Specifically with time varying gradients and the potential to impact this implant?
Yes.
Less. Because once we're outside the face of the bore, time varying gradients are essentially zero. Excellent. Does anybody, I'm not asking you to say, oh sure, we would scan that patient, no problem. But is there anybody who still, after we've gone through this, anybody who at the beginning of the lecture who said, I wouldn't consider doing this, is there anybody who still feels that it's not worth considering doing this study? Good, okay, excellent. That's the result I wanted. So the deep brain stimulator This is actually from magnet vision, the same thing that we showed, the magnetic fields. This is, you can actually put implants in a patient. So I put a deep brain stimulator in this simulated patient. And you can turn it so that the individual organ groups and skin are semi-transparent or opaque. So inside here is the deep brain stimulator. And here I have the patient positioned for a knee study, and we're showing the radio frequency energy. And here are our hot spots. And I'm going to use a tool and ask it to tell me exactly how much RF. So 0.02 times whatever the pulse sequence is. So if your pulse sequence is 2 watts per kilogram, the most that this would be exposed to is 0.04 watts per kilogram, 2/100ths of whatever your pulse sequence is.